and salivary gland. So we make sure that it will be complete set about GIT lecture. So intestinal obstruction can be mechanical 80% of the time, can be due to hernia, weakness or defect in the wall, adhesion. Adhesion happen after surgical procedure, right? Most of the time. Infection. Next time when I am teaching, come from the back door, okay? Volvulus. What is that volvulus? It's a twisting, right? Twisting of the bowel loop about mesenteric base. Intussusception. A segment of intestine which is telescope into the immediately distal segment. It's actually most of the time happen due to tumor. So tumor and infarct is 10 to 15% of the time. So you are seeing, I told you, intussusception is due to tumor. Where's your notebook? How about your friend? Make sure take note. So in children, if you have a pediatrics patient with the intussusception, the most common cause is what? Lymphoid hyperplasia. So ischemic bowel disease. Acute arterial obstruction. Do you think how is artery being obstructed? Due to what? I write it here, you will say. Atherosclerosis. So how atherosclerosis will develop? Because of anyone. Negative preposition. So this answer is for grade 1 student, not for medicine student. You explain the pathway of atherosclerosis, not you, anyone else. Anita, can you tell us the pathway of atherosclerosis? How it will develop? Due to foam cells. So how foam cells will develop? Microbes. Bacteria. Sit down, it's wrong. Ahmad, how patient will develop atherosclerosis?
Transport to the distal wall.
The distal?
The distal part.
Distal part of the abdomen? Because we should know, right? So we should understand. Atherosclerosis develops because we have perhaps high level of LDL, right? LDL is prone to oxidize. Correct? When LDL being oxidized, it will be the macrophages receptor, not microbes. Macrophages, right? Macrophages will eat it. Through what receptor? SRA, right? So it will receive all the oxidized LDL and it will become bigger. When it become bigger, we are calling it foam cell. Foam cell is activating different cytokines. And those cytokines will make if you remember the lining of the blood vessel, it's an intima. What's the second one? Medium. Media and adventice. Okay. In the medium, what do I have? Muscular smooth muscle cell. Right? Those muscular smooth muscle cells will be migrated. So it will make the fibrous glands. So I will see on your notes if you are writing, but I am saying. Okay, I am not telling you write the presentation. I am telling you write what I am telling you. That's what it will be. So another problem is aortic aneurysm. Okay? Then there will be weakening. And then another one is hypercoagulable state. Intestinal hypoperfusion also can cause ischemic bowel disease, like cardiac failure. So, Jasmine, can you stand up? Tell us what happened in the cardiac failure that patient developed ischemic bowel disease. Why do you think cardiac failure patient will develop ischemic heart disease? Because what? What is the job of heart? Okay, if it's failed, can it pump? No. Can blood go to circulation? No. If there is no blood in the blood vessel, what we are calling it ischemia, right? Okay. How about in the shock? Okay, class president, what happened in the shock that patient developed ischemic bowel disease? Yeah. Blood flow will decrease, right? Blood flow will decrease. Dehydration, right? Same thing. Vasoconstrictive drugs, such as, can you give us one vasoconstrictive drug? What? Angiotensin. Angiotensin converting enzyme, what?
Constrictive acids. You have drugs like ARBs and ACE inhibitors. That's pretext.
Okay. Mesenteric venous thrombosis. Why we will develop venous thrombosis, by the way? In what case you can see that patient develop thrombosis in the venous, in the vein? When patient have polycythemia vera. Search it in the Google. What is polycythemia vera? And one of you explain. Be active in the class. Polycythemia vera. Anita, read it. What did you find? What? Polycythemia vera. There is lots of red blood cell production, right? So it's prone to cause what? Very good. And also cirrhosis, right? Cirrhosis also can cause problem. Why? Why liver cirrhosis can make mesenteric venous thrombosis? Because when there is cirrhosis, there will be blockage, right? So it will be backflow from the portal vein, so there will be venous thrombosis. So major variables in ischemic bowel disease: severity of vascular compromise, time frame during which is developed, and vessels affected. As we said, transmural and mural infarction, right? They are two different. Depends, is it artery or it's vein? Okay. So ischemic bowel disease, mucosa, as you see, is a hemorrhagic and ulcerated. Atrophy. Why patient will develop atrophy? What is atrophy? Very good. Enlarging of the surface epithelium, inflammatory infiltrates, coagulation, necrosis, and perforation. Serositis with the purulent exudates, and lesion may be continuous, but more often segmental and patchy. So what is angiodysplasia? Anyone? Can you tell us what is angiodysplasia?
This is like dilation of blood vessel in the mucosal and submucosal.
Why? What's the definition of angiodysplasia?
Hollow and fertile blood.
She's correct that she get confused. So malformed submucosal, and you want to answer? Okay, go. Very good. Most often occurs in the cecum or right colon. Accounts for 20% of lower intestinal bleeding. Intestinal hemorrhage may be chronic and intermittent or acute or massive. So very important things we should learn today, and I add some information from Harrison US edition about malabsorption syndrome. Occurs when there is a disturbance in at least one of the four phases of the nutrient absorption. 1. Intraluminal digestion, terminal digestion, transepithelial transport, and lymphatic transport of absorbed lipid. Symptoms will be what? Diarrhea. That we want to little bit discuss about diarrhea more. According to Harrison, what is definition of diarrhea? So diarrhea is the most common symptom associated with disorders of absorption. For most patients, diarrhea as a symptom is defined as an increase in stool number or frequency, or change in the constancy. Normal bowel pattern may vary from as many as 2 to 4 bowel movements per day to 1 stool per week. It is critical to use an objective measure of diarrhea to help direct evaluation. Because most of us really don't know what's diarrhea, right? Inhaled stool volume or weight less than 200 milliliter or less than 200 gram respectively in 24 hours. Collection of stool for weight divided to volume determination is one of the most useful tools for the evaluation of diarrhea. In particular, 72 hours collection for weight to volume and fecal fat determination is the gold standard for documenting the presence of steatorrhea or fatty stool. So what is steatorrhea? Defined as increased stool fat excretion to more than 7% of dietary fat. It's common manifestation of malabsorption, right? Have you experienced this, specifically after food? If you eat fatty food, there might be immediately you go to CR and you will see the fatty stool, right? Steatorrhea. So result in large, bulky, and malodorous stools. So this is important we understand how lipid going to be absorbed. Do you remember your physiology? So the absorption of lipid, right, will be, there's a lots of process there, right? Starting from lipase. And then when we are in the stomach, we are getting help of pancreatic lipase, right? So pancreatic lipase will break down this exogenous fat, which is triglycerol. So it will break down to what? So this is my triglycerol, right? And then this is my pancreas. This is one ampoule of water. And there's opening there. Ampoule of water. There are all the, and this is the pancreatic duct. So, as you remember, ampoule and blood, we have here one gallbladder, right? The gallbladder is contain what? Inside gallbladder, what do we have? Bile. Okay, so we have bile. So when this fatty food arrive to the second portion of the duodenum, what will happen? There is an eye cell here, right? Eye cell. Will secrete CCK. Okay? The CCK will go to the blood and will go to the gallbladder and will make contraction of the gallbladder. And then bile will be excreted. Is it the only thing CCK do? No. It will also go to pancreas. It will help to excretion of lipase. How it will help? It will open the sphincter of Oddi, right? It will relax the sphincter of Oddi. So the lipase also will drain here. What else CCK will do? It will reduce the gastric emptying, right? Okay, so 3 things we learned. So now the food is here. The Triacylglycerol is here, and the lipase attached to it. Of course, there is lipase and there is co-lipase. Correct? So if you learn this all 10 slides continuously, it will be very easy for you. All the disease, it will be very easy. So what we have there, let me change my. Okay. So we have what? Lipase and tell me. I am forgetting what? Lipase and co-lipase. Okay. So now they've been attacking to my triacylglycerol. What will happen to triacylglycerol when it's being attacked? Okay, just wait.
Sure.
Please really carefully listen. Now, all after this slide, all will be disease related to this family. So now lipase and co-lipase going to attack the triacylglycerol, correct? So let me just enlarge over small intestine here. So from the starting from very big. So this triacylglycerol being attacked by what? Lipase and co-lipase. So when it's attacked to it, what will happen? What will be the byproduct? The byproduct will be free fatty acid and 2 monoglycerol. Okay? Monoacid glycerol. Very important that we'll see the disease later. So when I have this, I also remember there is bile, right? I've had bile also coming here. So now it's something like this. There is a bile salt surrendering. When bile salt surrendering, we know that the lipid droplets, when they encounter water, because bile has water, they are forming what? M, E, or micelles, right? Some people call it micelles, some people call it B cells, right? Okay, so now we form it already. This micelles is helpful, right? Because it's made the absorption area to increase, correct? So now we are going to absorb it in over, what's this? Intestine. The lumen of the intestine. So what is the component of this micelle? Can you again recall? Is fatty acid and 2 monoglycerol, correct? So let me write it here. Fatty acid and 2 monoglycerol. When they are here, okay, they are going to see one enzyme here, very important. This fatty acid going to meet the enzyme for enzyme SH, which is currently coming from serine. Right, so coming from cysteine. Okay, so it will be what? Fatty acid coenzyme A. And then with this 2 monoglycerol will give to me triacylglycerol. Correct? This triacylglycerol will go where? It can go out by itself. No. That's why later we have disease. I will ask you the exam also. What do I need? I need apoprotein P48 to secrete chylomicron. So this is the chylomicron here, but it's a nascent chylomicron. It's not yet mature. So ApoB48 will help this triglycerol with chylomicron go to the lymph node, lymph first, and then will drain through blood. So now inside the blood, what do I have? Chylomicron. What is inside chylomicron? It's mostly triglycerol, right? Correct? That's why chylomicron is big in size but less dense. Correct? So now with this explanation, we need to answer the following pathological condition that we will see. But one thing more before that to say. The bile will return back through intrahepatic circulation. Okay? So let's see what our book want to teach us. So, bile salts are synthesized in the liver that we know. How we will synthesize the bile salt? With cholesterol. Correct? There is a 7-alpha hydroxylase enzyme which will help to synthesizing of bile acid. Okay, let me ask from your vice president. Stand up. You tell me what is the component of bile salt? It's water, 1, cholesterol, 2, what are others? It's bilirubin, right? Very good. Is it conjugated or unconjugated? Very good. So remember this. Bile acid are synthesized in the liver, secreted to intestinal lumen that we already explained. Constantly recirculated by absorption in the ileum. The ileum express fibroblast growth factor 19, which is physiologic bile acid sensor. Fibroblast growth factor 19 is secreted from the ileum into the bloodstream in response to bile acid flux and negatively regulate hepatic bile acid synthesis by affecting the transcription of hepatic CYP7A1. Why? Because when there is bile acid, I do not need anymore to secrete more bile acid. So this fibroblast growth factor 19 stop the secretion, help to this bile acid to be recirculate back. So one of the other type of the diarrhea is osmotic, okay, known as osmotic diarrhea. Malabsorption of the single nutrients like lactose. Okay, where do I find lactose? Where do you find lactose? In milk product, right? Milk and dairy products. Okay. What will happen if we don't have enzyme lactase? What will happen if we don't have lactase in our body? Will be lactose intolerance. So we will have diarrhea. Why? Because, by the way, lactose is sugar, right? So if I cannot absorb it, sugar will stay in the intestine, will absorb the water. Correct? That's why we will have what? Very good, osmotic diarrhea. Other type of diarrhea that I think my older brother, Dr. Ian, will teach you in microbiology and parasitology. It's infectious, right? Infectious type of diarrhea that we are also going to little discuss about it in Patho. So diarrhea, according to Robbins, is increase in the stool mass, frequency or fluidity, typically greater than 200 grams a day. 4 major categories that we explained all of this already. Secretory, osmotic, malabsorptive, exudative diarrhea, which is inflammatory disease characterized by purulent and bloody stool. Let's go to one genetic condition first. It's cystic fibrosis.
What do you know about cystic fibrosis? Can anyone explain? What do you know about cystic fibrosis? What's the problem in the cystic fibrosis? It's what?
It affects the cell that produce mucus and digestive juices.
Actually, it's here. The answer is here. Absence of epithelial cystic fibrosis, transmembrane conductance regulator. Answer is here. Okay, which chromosome do you think will be this disease related to? Chromosome number 7, right? There will be what? What amino acid will be deleted? You should know this, huh? Because it's important for your board exam. Phenylalanine, right? Phenylalanine will be deleted and position 508. Okay. So what is the job of this CFTR normally? It's for chloride, right? It's either help to chloride go to the cell, if it's in the sweat gland, or if it's help to chloride go outside of the cell. When it's in the, for example, lung bronchus, it's make the mucus secretion to become not too much viscous, right? Become like added fluid to it. So it can be by overciliary, can be go out, can be move. So imagine if we don't have this CFTR and we go to over in this topic, we are in GIT, right? We are in the intestine. And then we have a baby, for example, 5 days old, and baby has this problem, cystic fibrosis. What will happen? Do you think baby can have defecation? No, right? There will be obstruction because there will be no chloride movement. So it will be very hard stone. So it cannot pass, baby cannot pass it out. And baby also will have what? They will bring the baby with distended abdomen, right? And baby keep crying with distended abdomen and perhaps vomiting because the digestion is not work, right? There will be vomiting. And that vomiting will contain of bile, right? So it will be greenish, correct? So do you think this kind of patient in that pediatrics age, newborn, can they survive? Very less chance, right? Because patient also will develop bronchiectasis and they will die through pulmonary cardiorespiratory arrest. Okay, we go to another important disease, is celiac disease. What do you know about celiac disease? It's actually immune mediated, right? I asked this question yesterday. You might say it again, same question. Immune mediated enteropathy triggered by ingestion of gluten containing food. Like what? Very good. We have silent. Okay.
Online students, please wait. Doc is on a call.
It's associated, this disease is associated with HLA. Can you see DQ? DQ 2 and 8. So take note, we might ask it in the exam. HLA DQ. So let me write it here so the student can see. HLA DQ, right? What type? 2 and 8. Very good. So let's go forward. So it's presence of immunoglobulin A antibody to tissue transglutaminase. Okay. Sometimes it's present immunoglobulin A, but sometimes patient might have deficiency of immunoglobulin A. So what you should do, you should also look for immunoglobulin G. Okay, if in case of a patient has deficiency in immunoglobulin A. Okay. Celiac disease morphology is intraepithelial lymphocytosis, crypt hyperplasia, villus atrophy, and other features are increased plasma cells, mast cells, and eosinophils. So that's why we call it in the start. It's what? It's immune mediated, correct? It's associated with the T cell lymphoma, not B cell. It's T cell lymphoma. Do not get confused, Vice President. It's T cell lymphoma. Okay. Another disease we have known as tropical sprue. It's really, I was reading it, it's unknown cause, not really clear. So visitor living in the tropics like Philippines, no definitive organism, and it's overgrowth of aerobic enteric bacteria that cause malabsorption. Autoimmune enteropathy, you remember IPAX. What is that IPAX? It's immune dysregulation for eye. Take note, you might see it later. Polyendocrinopathy, enteropathy, and X-linked. So it can be also, in the question we might ask about the mutation, right? It's a germline mutation in FOXP3. So lactase deficiency that we already mentioned, right? We already discussed this. Okay. I want one of you explain to me what is a beta lipoproteinemia. Okay, let me ask from Thailand. You. What is the meaning of a beta lipoproteinemia? What's the definition? Okay, if you don't know. What is a beta lipoproteinemia? You. I am not asking is it inherited or not inherited. What's the meaning? Inability to? One by one. You. Inability to secrete? No, wrong. You. Do not read that.
X. Inability to absorb X.
No. Rare, autosomal, but I am not asking if it's rare or common. From Thailand. What is a beta lipoproteinemia? Anita. Very good. So A meaning absent, right? Absent of the beta, right? We talk about beta, what is it? All the beta groups. What are those? One beta group also we have. Can you name it? Is B48 and another one is B100. B1. Right? 100. Where are you looking at me? It might be wrong.
P100 or P200? 100, right? P100. So we have two type of beta lipoproteinemia. Okay. As we discussed earlier, remember, Ahmad, look at me. There's nothing in your place. So what was the function of beta 48? Help to chylomicron to, right, to transport to lipo. I mean to secrete it. It's like secreting the chylomicron. Secreting where? To lymph. And then from lymphatic circulation to artery. Okay. If I don't have beta 48, can I make the chylomicron go out? So simple. How about ApoB 100? What's the job of ApoB 100? What is this? Liver. So where is ApoB 100? It's in the liver. And what ApoB 100 do? It's secrete very low density lipoprotein. Right? So we also don't have this. What is it? What's inside very low density lipoprotein? What's inside it? What is carrying? It's like a taxi, right? What's inside this taxi? Who is the passenger? Triglyceride, cholesterol still. Which one? No, triglycerol. Mostly it's triglycerol, right? You just need to always refresh yourself. So this one is vice president is different, right? This triglycerol is the liver, right? We are making it out from liver to fat cell. Correct? To where? To fat cell. You may ask me, so where this triglycerol came from in the liver? From the pizza we eat, right? And that pizza is carbohydrate. And that carbohydrate will convert into acetyl coenzyme A. That acetyl coenzyme A will go to fatty acid synthesis. Then it will give me one fatty acid, two monosaccharides, will give me one glycerol. So it will transfer. So now you tell me, if absent ApoB 100 and absent ApoB 40, I do not have in the circulation VLDL and chylomicron. We also see ApoB 100 in the surface of what lipoprotein? We have only one pair, LDL, right? ApoB 100 is also a LDL. So if I don't have ApoB 100, the LDL cannot be reabsorbed by its receptor, by LDL receptor. So it will be also problematic. So now let's see what they say.
Inability to secrete triglyceride-rich lipoproteins. What are those two? Lipoproteins. One is chylomicron, another one is VLDL. So mutation in the macrosomal triacylglyceride transfer protein that catalyze the transport of triacylglycerol, cholesterol ester, and phospholipid. You may tell me that Dr. Mesam said only triacylglycerol, but book say cholesterol ester, cholesterol, phospholipid, because it has a long discussion. So if you didn't learn biochem online, you should attend the biochem class, because you might always ask from yourself where phospholipid came from, right? It might be question in your mind. Why book say cholesterol? In the top sentence is triacylglycerol rich, but in the bottom is cholesterol, cholesterol ester. Why? Because, of course, this LDL transferring their content, if it's cholesterol, it will be transferred to HDL, from HDL to LDL. Mostly from HDL transfer to LDL is cholesterol ester. Why? Because LDL is a lipoprotein that will go to all over the tissues and will give this cholesterol. That's why maybe there will be problem also in cholesterol state. Why? Because LDL also is not working. Correct? So how about phospholipids? So where that phospholipid came from? What do you think? Why they said phospholipid? What is your idea? Okay, you, yeah. Cell membrane. And then? So what? Phospholipid, when you hear phospholipid, cell membrane, finish? In this content of this lecture, what do you think? How you are synthesizing phospholipid? From phosphatidic acid. Phosphatidic acid coming from rejoining of free fatty acid and 2 monocyl glyceride. Okay, it will be phosphatidic acid, and then from there you will have phospholipid. So let's go to infectious enterocolitis. It's already 2, so we should speed up. So I will not anymore explain, I will just read. Vibrio cholera. So it's a gram-negative, non-invasive bacteria. So non-invasive bacteria causing cholera. Enterotoxin causes the disease. 5B subunit and single A subunit. You know that it will work with G proteins, right? Flagellar protein, motility and attachment, and take note of this word, you might see it later. Let's see who is really listening. What is that? Very good. Hemagglutinin, bacterial detachment and shedding in the stool. So it's related to Vibrio cholera. So another disease, Campylobacter enterocolitis. Most common bacterial enteric pathogen in developed countries and important cause of traveler's diarrhea. 4 virulence factors: motility, adherence, enterotoxin, production, and invasion. Diagnosis is what? Through stool culture. Biopsy is non-specific, colitis, cryptitis, and crypt abscesses. We go to another one. Take note of this. We might also ask this in the exam later. Shigellosis is proliferative intracellularly within M or microfold epithelial cell. Mucosa will be hemorrhagic, ulcerated with pseudo membrane. So what you will see in the patient? Clinical manifestation: diarrhea, abdominal pain, and fever, dysentery. So it's like Reiter syndrome or hemolytic uremic syndrome. Salmonellosis coming from Staphy or S. enteritidis. So Staphy is a typhoid fever. So virulence factor is type 3 secretion system, flagellin, lipopolysaccharide, and epoxylin A3. Diagnosis also stool culture. How about typhoid fever? What typhoid fever will do, Ahmad? Gallbladder colonization, right? S. typhi or S. paratyphi associated with the gallstone and chronic carrier state. Survive in gastric acid. Morphologically is enlargement of the Peyer's patches. Where is Peyer's patches in anatomy? Sige. Where? No, which in the small intestine? Is it in the duodenum, in the ileum, in the jejunum? You do not guess, I will. Which one? Okay, you. You. Ileum. What's your answer? Jejunum, are you sure? Okay, sit down. Helium. So you study, okay, next time. Actually, answer is here. Why are you saying jejunum? Spleen, the typhoid. What is your name? What? Listen, listen to lecture. Typhoid fever, spleen will be enlarged, soft with uniformly pale red pulp, obliterated follicular markings, and prominent phagocyte hyperplasia. Do not get tired, Vice President. We cannot give break time. Liver is randomly scattered, right? Scattered foci of parenchymal necrosis replaced by fibrous forming nodules. So clinical manifestation is what? Anorexia, bloating, bloody diarrhea, rose spot, and extraintestinal manifestation. So after this, we will give you a little break time after this too. Because I am seeing everyone stretching. So Yersinia is what? Is composed of two enterocolitica and pseudotuberculosis. So what's the morphology? It's involved what? Small intestine? Very good. Only ileum? And? Very good. And regional lymph node? And also Peyer's patches, hyperplasia and bowel wall thickness. Actually, Peyer patches function is important in immune cell. Okay. Clinical manifestation is abdominal pain, fever, diarrhea, and extraintestinal symptoms like pharyngitis. So E. coli is very famous, right? Is it gram-negative or positive? Enterotoxigenic, principal cause of traveler diarrhea, enterohemorrhagic, enteroinvasive, and enteroaggressive. So 2:11, 3 minutes break. Okay, 10 minutes break, and then we continue. So let me go forward, class. We go to pseudomembranous colitis. So it's about Clostridium difficile, antibiotic-associated colitis. It will cause what? Diarrhea. Most commonly implicated in is a third-generation cephalosporins. Toxins and morphologically, pseudomembrane formation denuded surface of epithelium with what? Mucopurulent exudate, dense infiltrates of neutrophils, and occasional fibrin thrombi within capillaries. So very interesting disease. I have also very good explanation. I get it from Harrison. Yeah. Whipple's disease. What is it? The systemic tissue damage characterized by macrophages loaded with T. whippeli organism. So again, it will cause malabsorptive diarrhea due to impaired lymphatic transport. But what we said in this study, it's a systemic disease, right? Okay. Partially destroyed organism, because what happened in this disease, the macrophages eating this organism but cannot kill it totally. Okay. So when it cannot kill it, the partial of this organism left. That's why they call it partially destroyed organism are present in macrophages lysosome. That's why it's positive for PAS test. So what you will see in the patient, diarrhea, weight loss, and malabsorption. So you see presence of the foamy macrophages, pass positive in lamina propria, and large members of argiophilic rods in the lymph nodes. So seeing here, Whipple disease. So bacteria-laden macrophages can accumulate within the mesenteric lymph nodes. It can cause synovial membrane. It can deposit in the synovial membrane. It can even deposit what? In the cardiac valves and even in brain. That's why it's systemic. Let's go to infectious enteritis, such as ascaris, and I think you have parasitology this semester, right? Yeah. Strongyloids. So viral gastroenteritis, Normovirus cause half of the gastroenteritis outbreak worldwide and common cause of sporadic gastroenteritis in developed countries. Rotavirus is most common cause of severe childhood diarrhea and diarrhea mortality worldwide. Adenovirus, the second most common cause of pediatric diarrhea. So as you see, when we continue this lecture, some of the part of lecture is just memorizing, right? You will memorize for exam and you will forget. So amoebiasis is the most frequently in the cecum and ascending colon. Flask-shaped ulcer. Penetrate in splenic vessels and immobilize to liver and will cause abscess. Cryptosporidium is a small blue sphere that appear to lie on top of the brush border. So where is brush border? In the small intestine, right? So contaminated drinking water is the most common cause and most common way that you can get this disease, right? It's acute, self-limited in the normal host. Chronic diarrhea will be resolved if patient has immunodeficiency or AIDS. So, yeah, Giardia lamblia, most common pathogenic parasitic infection in human. So, intestinal schistosomiasis is another one. Let me move to irritable bowel syndrome. So the age group will be affected are 20 to 40 years old. Clinical criteria is abdominal pain or discomfort at least 3 days per month over 3 months. Improvement with defecation. Change in stool frequency or form. So let me differentiate ulcerative colitis and Crohn's disease. I told you here, see the table 17.8 in the page 808. However, I also make you here the table. Ulcerative colitis is limited to colon and rectum, extend only into the mucosa and submucosa. Crohn's disease, regional enteritis, any area of GIT, typically transmural. So please see here, ulcerative colitis and Crohn's disease. Could you take picture of this? So you can always have it with yourself. Location begins at rectum and continuously moves back anywhere up to cecum. But in the Crohn's disease, Ahmad, what's the problem? Terminal ileum is the most common. So expect that to be asked in the exam. Vitamin B12 deficiency also result in the Crohn's disease. Why? Why there will be vitamin, the spelling of Crohn's is wrong. Huh? Why there will be the, why there will be vitamin B, not you. Huh? Okay, Jasmine, stand up. So I know few names, right? Jasmine, Vice President, and I will ask you if you look at me like that. Okay, Jasmine, tell me why patient will develop vitamin B12 deficiency? Because inappropriate diet. Thailand, why patient will develop vitamin B12 deficiency in Crohn's disease? Any idea? So I will give you big zero tomorrow, so do not tell me. I will also say like this. Oh. When you ask me, look, I fail, I will say no. You, Ahmad, why in Crohn's disease we have vitamin B12 deficiency? Class President, why? It's not maybe. Why we have vitamin B12 deficiency? Because of neurologic problem? What do you mean people don't eat enough diet? Make it correct English. I am not really that good English, but make it correct. Ano? My English is Filipino English, right? Tagalog English. Okay, so sit down properly like a student. Stand up. Yan. You cut your hair next time when you come to class. Then tell me. Yes, I forgot about. I remember Dr. David, he was telling something. Okay, tell me. Grade go to Saturday, Dr. David. Yeah, tell me. So I have a comparant.
Dapat sa aluminium, even if it's some documents express my aluminium.
Can I see your notes? That takes place in ileum. So when are you not answering it? Is the way you answer that? Pero ileum, vitamin B12. Very good. Because its absorption of vitamin B12 is where?
And the aluminium.
Okay, can you tell me beside you, Mr. In order vitamin B12 absorb, they need vitamin B12 to bind to something. What's the name of that something? Which is coming from parietal cell. No, not you. Okay, intensive cardiovascular very expensive. Okay. How about folic acid. Their folic acid will absorb. Because I showed it to your classmate, vitamin B12 will absorb in you. How much folic acid? Who is that? What's your name? Where's your notes? Why can't work it? Next time bring blackboard here. Are you teacher? Are you going to check something between your the blackboard? Where is your note? Your notes is good. Say, you should pay. Take note. Do not rely to book. Because I am also sometimes going outside when people right outside the device. Take note. Now, Madam, where is your note? So the blue one is important points, red one is just. How about you?
Next time bring, anyway, next time it's not me. You don't take note, it's up to you. So, rectum is least common, right? So what is the symptoms? What is LLQ? What? Lower left quadrant. Is it not better we say left lower quadrant? What do you think? Left lower quadrant. So, and then right. Okay, very good. So inflammation is crypt abscesses with neutrophils, right, in the ulcerative colitis. How about in Crohn's disease? However, in Crohn's disease, lymphoid aggregated with non-cacheating granuloma in 50% of cases. So we will see in the gross appearance in the ulcerative colitis, pseudopolyp. Okay. And how about in Crohn's disease? Cryptin fat, stricture, right? We will go to slides also see here. In the Crohn's disease, any area of GIT, but most common site is terminal ileum. That is where vitamin B12 will absorb. Small intestine, 40%. Skip lesion, stricture are common. Earliest is aphthous ulcer, but however, it will be cobblestone appearance, fissures, and creeping fat. So what is PMN? Jasmine. From Thailand, what is PMN? You have book, right? What is PMN? Yeah. Very good. So distortion of mucosal structure, Paneth cell metaplasia. Ahmad, what is the definition of metaplasia? I am very toxic, Professor. I can feel it. Okay. Actually, I look like my professor, the one called me. When I was studying PhD at Biochem, he always asked me, what is this? What is, I wanted to put the book to his hand. Okay, tell me now. I know the feeling because I go through it. It's okay, okay. So what is metaplasia? Definition? President of class, stand up and explain metaplasia to the class with the loud voice. Without looking to your camera. Okay, go. Okay, what's that? No. Is it the way I explained? Change of cell, change of size? Is it clothes? So where is coming from? If it cannot find in the tissue. To explain the change of one mature cell to another mature cell in response to stress. is metaplasia. What's the most common example of metaplasia? Which is happening in the esophagus. Start with letter B. Very good. Okay, so let's go forward. Clinical feature of the Crohn's disease. There will be diarrhea again, fever, and abdominal pain. 20% of patients have right lower quadrant pain, fever, and bloody diarrhea. Periods of active disease are typically interrupted by asymptomatic periods that last for weeks to many months. So sometimes we have also extraintestinal manifestation in eye, right? In the polyarthritis and clubbing of fingers. That's 3 are most common. So go to ulcerative colitis. Always involve the rectum and extend proximally. What time is it? How many minutes we have time? Oh, it's almost 1 hour. Ulcerative procolitis or proctosigmoiditis. Gross appearance is a broad-based ulcer, pseudopolyp, and polyps may fuse to create mucosal breach. So you are seeing, right? There will be mucosal atrophy. Inflammatory infiltrate is diffuse and generally limited to mucosa and submucosa. Crypt abscesses, architectural crypt distortion, epithelial metaplasia, and granulomas not present. There is no granuloma or granulomus formation. So it can be persist for days, weeks, or even months before they subside. Most patients have clinically mild disease, at least one experience relapse during 10 years period. So let me go to sigmoid diverticulitis. The outpatching of 0.5 to 1 centimeter in diameter occurs in regular distribution alongside of the Tinea coli. So macroscopically, you will see thin vault composed of flattened atrophic mucosa, compressed submucosa, attenuated or most often totally absent muscularis muscularis what? Propria. Hypertrophy of the circular layer of the muscularis propria is also common. So we are seeing the diverticular, right? So it's about perforation. So polyps. The most common neoplastic polyps is adenoma. Potential to progress to cancer. That has many explanations that you'll be ready. We will explain about polyps, that how this adenoma will be cancer, right? Will be metastasized or will be adenocarcinoma. Because adenoma is a localized tumor. So juvenile polyps in the children less than 5 years old, most common mutation is SMAD4. Majority are located in the rectum. Morphology is less than 3 centimeter. Smooth surface and reddish lesion. Macroscopic is dilated glands filled with the mucin and inflammatory debris, mixed inflammatory infiltrates. Another low yields is a Pitt-Jekyll syndrome, multiple GI, hematomatous polyps, and mucocutaneous hyperpigmentation. Associated with increased risk of several malignancies, germline, heterozygous loss of function mutation in gene LKB1 and STK11. So most commonly happen in the small intestine. So yeah, that's only important here. But I want to show you this one. See, we said that is hematoma, like it's a small blood vessels will be ruptured. Okay, you see the lips and even the hand. Codden syndrome, autosomal dominant, is also hematomatous polyp syndrome. Loss of function mutation in the PTEN. GI hematomatous polyps, lipoma, macrocephaly, hemangioma, and in males, okay, pigmented macules and glands of the penis, you will see in the males. BRR syndrome is a mental deficiency and development delays is other characteristics of this disease. Okay. I don't know they will ask these questions or not, but we should cover it anyway. Cronkite Canada syndrome, so it's coming from Canada, right? Cause is unknown. Hematomatous polyps of the stomach, small intestine, and colorectum. Non-polypoid intervening stroma shows crypt dilation and lamina propria, edema and inflammation. And you will see in the patient nail atrophy and splitting, hair loss, hypopigmentation, and cutaneous hyperpigmentation. Hyperplastic polyps. Pathogenesis is a decreased epithelial cell turnover and delayed shedding of surface epithelial cell, leading to peeling up of goblet cell and absorptive cells. There is no malignancy potential, right? Must be distinguished from the sessile serrated adenoma, which has a malignant potential. We will discuss it later. Morphology of hyperplastic polyps, most commonly in the left colon, less than 5 millimeter in diameter, mature goblet and absorptive cell. And you are going to say that serrated surface architecture, morphologic hallmark of the lesion. So this is the picture of the hyperplastic polyps. Look at the difference, Ahmed. Adenoma, hyperplastic polyp. Which one has potential to turn to cancer? Adenoma. Neoplastic polyp, colonic adenoma, benign polyps that are precursors to the majority of the colorectal cancer. Small, often what? Pedionucleated with the fibromuscular stalks to large sessile lesion. Presence of epithelial dysplasia, nuclear hyperchromasia, elongation, and stratification. Where is that student that I caught him while he was receiving from his classmate? The answers. He's scared to come or he just go to collect the documents or collect the answers? But he will be online. Okay. So adenomas architecture, tubular, small. So pedunculated, composed of small rounded glands. So you will see also here tubulovilus. Vilus is a large and sessile with a cylinder villi. Intramucosal carcinoma is a breach of the base membrane and invade the lamina propria or muscularis mucosa. So this is a colonic adenoma. Okay, so we are already there. This is very important. Familiar adenomatous polyposis. So it's an autosomal dominant, right? Mutation in the adenomatous polyposis coli, which is known as APC gene. What is this gene? What's the function of this gene? Is tumor suppressor gene, right? Tumor suppressor gene. Colorectal cancer develop often before age of 30. Potential neoplasia at the other sites like ampulla of water or stomach. Extraintestinal manifestation, hypertrophy of retinal pigment epithelium. So let me go forward. There's a very good image. Okay, we are almost there. So Gardner syndrome, it's same as familial, you look at here. Familial adenomatous polyposis. But the difference is, to addition to that, there is also osteoma of the mandible. Okay. In addition to that, there is a osteoma of the mandible, skull, or long bones, epidermal cyst, desmoid tumors, and thyroid or dental abnormalities. Turcot syndrome is intestinal adenoma, CNS tumor, medulloblastoma. So look at the genes. What is HNPCC? Hereditary non-polyp. Okay. What is DNA mismatch repair? So okay, here, I like this picture, okay. So let me explain to you what happened, right, to this patient. So germline meaning inherited, somatic meaning acquired. Depends. I may have it inherited from my father. One copy of the gene is knocked out, and another copy will knock out also eventually. Okay. Or it might be somatic, meaning acquired. I get it. I just have it. You will see that Dr. May's father don't have colorectal cancer, but he have. Okay, somatic. So what happened here? Methylation. What is methylation? Methylation abnormalities, inactivation of the normal alleles. So meaning to say, APC become inactivated. So you explain to me, as you. What is methylation?
Methyl group is added.
Can you tell us what's methylation? What do we mean by methylation? As well as the name, what is methylation? This understand. So sit down. You. Yeah. What is methylation? Can you explain to me? Do you want microphone? Okay. Tell me. Yes, enough. Methylation of DNA. Okay, what will happen if we methylate the DNA? Mutation will happen. Are you sure? Are you sure or no? Ahmed, is he correct? Methylation happened in DNA, and then he said after methylation, mutation will happen. Is he correct? You. He's correct. Anita, is he correct? So methylation happened in the DNA, and it will cause mutation. Why it will cause mutation? If there is methylation. DNA become? What do you mean by abnormal? At least it has some idea, right? So methylation happened in the CPG island, right? Cytosine guanine island. So its methylation will be mostly in the cytosine. So when there's methylation, gene will be silent. Silencing of the gene. Gene will be what? Shut down. So if I make the gene, tumor suppressor gene shut down, what will happen? Tumor will grow. Yes. Right? The cell cycle will be continued. There is no stop. There is no barrier. Okay. So if you see later on in some book, they write it hypomethylation. What does it mean? Remember about these terms, hypermethylation, hypomethylation, because this book writes only methylation. But in your exam, they might put it there hypermethylation. So if you increase the methylation, the gene will be silent. Okay? If you make hypomethylation, what will happen? There's no forward. We are calling it what? Epigenetic. Okay? Epigenetic. So, do you know about Prader-Willi syndrome?
Yes, yes.
And Angelman syndrome?
Yes.
Okay, you tell me what is the
Pattern in Prader-Willi syndrome.
Yes.
maternal disomy and paternal chromosome problems there in primary.
So what is the problem there? There is methylation, right? In the fertilized egg. So it cannot anymore go under cell cycle, right? I mean, go under division. So it will be stopped. So imagine what will happen. So, but methylation, we are talking about DNA, correct? How about acetylation? If you hear acetylation, it's happening in the histone, right? The histone protein is different. When histone become acetylated, it's exposed to expression, gene expression. If histone become deacetylated, it will stop the expression. So you see the KRAS will be activated when there is a suppression of the tumor suppressor gene. The KRAS will be activated. Eventually, P53, okay, eventually P53 going to be, what is P53? Guardian of the tumor suppressor genes, right? Guardian. So when P53 also going to be inactivated, you are going to see additional mutation and gross chromosomal alteration. It's actually, I write it here for those students who don't have idea, chemical modification of DNA. So DNA can be chemically modified by methylation of the cytosine nucleotide using methylating enzyme. Increased methylation of a DNA segment, less likely to be transcribed into RNA, and hence any genes in that DNA segment will be silenced. So increased methylation of DNA result to silenced gene. So we have a non-coding DNA. I will not describe all of them. Just I want you to know that satellite DNA, mini satellite DNA, and also microsatellite DNA. Because you remember this picture when I teach you last year? So the human genome has a gene-related sequence 30% and extragenic DNA 70%. Is important, and we will know that why is it important. So in the colon carcinogenesis, increased CpG island methylation in the absence of microsatellite instability. See? Mismatch repair pathway. Okay, by the way, where mismatch repair will occur? In which phase of cell cycle? In G2. Okay, in the G2. So when there is a mismatch repair, I mean when there is a there is a mutation in the mismatch repair, specifically MLH2 and MSH2, so it will lead to what? What condition? Hereditary, non, very good. So adenocarcinoma of the colon happen in the proximal colon, polypoid exophytic. Distal colon is a napkin ring, constriction and luminal narrowing. So clinical manifestation is right-sided. We have also left-sided. If it's right-sided, it will cause fatigue, weakness due to iron deficiency anemia. If it's left-sided, it will be occult bleeding, changes in the bowel habits, crampy lower quadrant discomfort. Colon carcinoma, two most important prognostic factors: depth of invasion and presence or absence of the lymph node metastasis. So liver is the most common site of metastatic lesion. So I need to little bit speed up. Let me see. Where are we? So almost we are there. So please read the table 1711, okay? So you are seeing the colon cancer staging, T and M. What is T? We said already, depth of invasion. What's N? Lymph node involvement. That's M. So tumor of anal canal, upper zone is columnar, mid zone is transitional, and lower third is stratified squamous. So So basaloid carcinoma, coloconogenic carcinoma is the entire tumor displays basaloid pattern. What is SCCA? Which is HPV related. What is SCCA? No. I know HPV is related to that, but here is not that what we meant. Who can say in online? What? Anita. Okay. So why is related to HPV? You try. What is HPV? Okay. What will happen if I have HPV? How it will cause cancer? That's our point, diba? It will cause cervical cancer, but my question is, okay, it's actually there is no metaplasia. Here will be dysplasia. Okay, dysplasia. But why do you think HPV can cause cancer? Because HPV going to silent the retinoblastoma, right? It has a E6. It has something will be released from HPV. It's E6, another one is E7. Correct? Do you remember? Okay. So SCC is what again? Squamous. Hemorrhoids. Thin wall dilated submucosal vessel, pain and rectal bleeding. Treatment is rubber band ligation, infrared coagulation, or the best treatment for this is that depends the hemorrhoid, right? Depends to the bleeding. But I think you can see still the slide, right? Here is out, but we are inside. Yeah, I think Amy, you get to another meeting. So last one is almost the last one is appendicitis. Progressive increase in luminal pressure that compromises venous outflow. Luminal obstruction, fecalate gallstone, and what more about appendicitis? The acute supportive appendicitis, acute gangrenous appendicitis. So clinical manifestation is periumbilical pain that localized to the right lower quadrant. Patient will have nausea. You will see lots of cases. Vomiting, low-grade fever, and remember about McBurney sign. Okay. So in the appendix, we might also have a carcinoid tumor, but it's very rare. So tumor of the appendix, pseudomyxoma peritoneal, and mucocell, mucosinus cystadenoma, and mucosinus cystadenocarcinoma. So, there is something we call it peritonitis, the inflammation of the peritoneum. Result from what? Bacterial infection or chemical irritation. I think many students are absent today, right? Why? They go to UV, all of them. Leakage of bile, or they couldn't go Tuesday, why Monday? UV may don't know today, I will teach. Okay, leakage of bile or pancreatic enzymes, perforation of biliary system, acute hemorrhagic pancreatitis, foreign material, endometriosis, and ruptured dermoid cyst. Peritoneal infection, bacterial peritonitis, which will be due to perforation of the bowel content, right, to the peritoneum. Actually, yesterday one student asked me if one person drink acid, what will happen for suicide? Where is he? Is that you? I thought you are absent, right? It will cause perforation, you see, and peritonitis and death. Spontaneous bacterial peritonitis, cirrhosis or ascites, nephrotic syndrome. Okay, what is nephrotic syndrome? Ahmad, do not look at outside. Look at me. What's nephrotic syndrome? We have nephrotic, we have nephritic. What's the difference? Okay, you eyeglass. Problem in the kidney. Very good and clear answer. Sit down. So of course, it's problem in the kidney, right? It's nephron. In nephrotic syndrome, what will happen? You will lose albumin, right? Protein. That's very important. So cyst in abdominal cavity, blind lymphatic channels, foregut and hindgut, diverticula that pinch off during development, urogenital ridge or its derivatives, mold of infection, and sequela pancreatitis. So how many left? Okay, two more. Tumor in peritoneal cavity, primary tumor is mesothelioma. Desmoplastic small round cell tumor is a reciprocal chromosomal translocation. Secondary tumor is peritoneal carcinomatosis, ovarian and pancreatic adenocarcinoma. So you are seeing the peritoneal mesothelioma and demoplastic small round cell tumor. So let's go to the oral cavity. Okay, take picture. This was not in our schedule they give to us, right? However, Dr. Miliari give to me syllabus. It's in the syllabus. Okay, so that's why when I read the syllabus, I immediately include it. So describe the following oral cavity pathogenesis. Just learned it, cleft plate and lip. What is the presentation? Cleft lip and plate usually occurs together, right? Due to failure of facial prominence to fuse, right? One superior, two from, because it's coming one from superior, two from side and two from below. They are failed to fuse, right? We are calling it prominence. Aphthous ulcer, maybe all of us experience it, right? It's what? A painful superficial ulceration of the oral mucosa is a gray base with the surrounding erythema. It can be actually arise due to stress and it spontaneously will also resolve. Beckett syndrome is a Turkish name, right? Coming from the Middle East. I think Ahmad knows where is Turkey. So recurrent aphthous ulcer, genital ulcer, and uveitis, and can be seen in viral infection with unknown etiology. Oral herpes coming from when you have herpes simplex virus, right? Type 1. Type 2 is in the genitalia, remember, coming from sex. And type 1 is in the oral. So remember that I don't have, but I might have herpes simplex virus type 1, which I don't have. It might be disappear, right? And it might appear because it's virus. Like what? Like human papilloma virus. You go to dermatologic or aesthetic clinic, they will put the laser, it will fall off. Okay, that wart, genital wart. But it doesn't mean that you don't have that virus. You are carrier. You might to transfer to another one to another one. Okay, so specifically in females, you will know that you have human papilloma virus when you are pregnant, right? So I see many like this. So the girl has only have one sexual partner, right? One. But the guy has already human papilloma virus. Female get it, no sign and symptoms. But when she's pregnant, immune system decrease because immune system share the baby. So it will develop. Okay, let me go So describe the squamous cell carcinoma of oral cavity. Description is malignant neoplasm of the squamous epithelia of oral cavity. Risk factor is alcohol that I know Ahmed is not drinking. How about others? Who drink alcohol among you? Nobody. So tomorrow I will see you in IT Park that you are drinking. Tobacco, who smokes? Nobody also. Ah, very good students. Common side is what? Floor of the mouth. So please take note about leukoplakia and erythroplakia. Leukoplakia is a white color. Erythroplakia is red color. Okay. Leukoplakia is look like candidiasis, which is happening in the AIDS patient. The tongue of them is really white color, but white plaque that cannot be removed. But in candidiasis, you can remove it with the tongue depressor. You can remove it. So erythroplakia is a vascularized leukoplakia and highly suggestive of squamous cell dysplasia. Do we have it? Yeah, there. In the lateral side of the tongue, do you see it? That's also very important. I forgot to tell. So hairy leukoplakia is caused by Epstein-Barr virus, usually seen in the immunocompromised patient, on side of the tongue and is not precancerous. Leukoplakia is cancerous. Can you differentiate it with hairy leukoplakia with leukoplakia? So salivary gland, Anita, you were asking me, it's mumps, the disease there, and it's bilateral inflammation of the salivary glands. It can cause in the man, if it's teenager who get this mumps, it can be even cause more problem, right? Such as infertility, right? So another one is sialadenitis. What's this? Sialadenitis is mostly unilateral inflammation of the salivary gland.